Dr. Dhavendra Kumar, Visiting Professor in the University of Glamorgan, Consultant in Clinical Genetics, University Hospital of Wales, Institute of Medical Genetics, Cardiff University, UK. His research interests include genetics of human malformations, cardiovascular genetics, targeted molecular therapy, to name a few. Our second chairperson is Dr. Anurag Singh, Professor of Pediatrics and ex-Superintendent Umaid Hospital. Last chairperson is Dr. Pramod Sharma, Professor and Head, Department of Pediatrics, Dr. S.N. Medical College, Jodhpur. May I request the chairperson to kindly take their seats and initiate the session. May I request Dr. Shubha Fatke ma'am to kindly orient us about Dr. S.S. Agarwal oration. Ma'am, please.
Respected chairpersons and my friends, it's really an emotional moment for me to talk about my teacher, who we can consider as father of all medical genetics education in India. More than 3 decades ago, he had the vision to start a department of medical genetics in a medical institute when there was none in India. So at that point of time, he being involved in the planning of Sanjay Gandhi Postgraduate Institute of Medical Sciences, he had an opportunity to tell the policy makers that he wants a department of medical genetics and a department of clinical immunology, and that's how these 2 specialties came into existence in India. That time many medical people thought, what is it about and this department, like many people were like not understanding the long vision he had at that particular time. So after these almost 3 decades of planning, in India the medical genetics has taken strong roots, as well as we have this Indian Academy of Medical Genetics, and really it is it's very important to pay respect to him in the form of oration, which most of our medical genetics people in India who are students of Professor S.S. Agrawal. So this is the second oration in late Professor S.S. Agrawal's name. Because of this moment, really some things I want to share about him. Whosoever came in contact with Dr. Agrawal was immediately impressed by his very high level of intelligence, algorithmic thinking, and vast body of knowledge. Not about genetics and immunology, but medicine. He was an excellent clinician and was a very bright student. As far as I know, the number of gold medals which he got in his MBBS career, the record in KGMC is yet to be broken. And his intelligence and vast knowledge, meticulous thinking, planning, he really gave the shape to Sanjay Gandhi Postgraduate Institute of Medical Sciences. Starting from building construction to the policies for academic courses, as well as everything from purchase procedures, research committee, ethics committee, everything he had been involved and closely gave shape to all those things, and that is why the Sanjay Gandhi Postgraduate Institute of Medical Genetics has a very strong research component along with the clinical and teaching components. He had been also involved in various bodies of like Indian Council of Medical Research, Department of Biotechnology, DST, and I would not be wrong in saying that he has practically given direction to the research in medicine for the whole country as such. And he has he used to push us to do some lot of things like including mice model for neural tube defects and so many things which we could never think of. And I remember lot of our arguments, and like I used to be unhappy because whatever we used to do, he was always like there was always much more to do. But that made all of us grow. We learned a lot from him with his close association for more than 2 decades. And I'm happy that now we really think of, and there are people who are doing lot of basic research, including, as Dr. Verma suggested, that we have to have now research in the direction of therapies in India. And at this point of time, I feel it feasible. So all this is long vision of Professor S.S. Agrawal. After his tenure in SGPGI as head of the department, as director of the institute, dean of the institute, he also worked as a director of ACTREC, Cancer Institute in Mumbai, and also gave shape to that particular institute. So there would number of awards which he had got, including S.S. Bhatnagar Award, UP Science Ratna Award, and so many things, really felicitated him and acknowledged his work done and efforts, hard work which he had done. But the most important thing I really realized 2 years ago, just a few months before his demise, that our department had some conference, and all the speakers were alumni of our department, and they were talking of something like all modern genetics, microarray and everything, and he was really excited and very happy to see that in front of his eyes, in 3 decades, the department and medical genetics has really grown up to his satisfaction. To satisfy him, as I said, was impossible, and he really felt that yes, me, Suraksha ji, and all our staff and our students are doing well. So he was really happy about it, and that is the satisfaction which we have, that he could see the department coming up. And I think this oration every year will make us remember his hard work, his intelligence, and I'm sure the vision which he had is for 20 more years ahead, and it will keep on guiding all of us. Thank you very much.
Yeah, welcome you back. It is my great pleasure to introduce Professor Priya Krishnani from Duke University, USA. She is the Division Chief of Medical Genetics. Dr. Krishnani has a strong background in medical genetics, and is one of the pioneer of therapy for genetic diseases, mainly the glycosyl disease called Pompe disease. It just happened that I also know Professor Y.T. Chen, and she's actually holding the chair of Y.T. Chen, and he is well known for the enzyme replacement therapy for Pompe disease. And so I will not go into detail, keeping time in mind. And so I would welcome Dr. Priya Krishnani for this oration in the memory of Dr. S.S. Agrawal. As you can see, the title of her talk is Treatment Advances in Medical Genetics, which is really the main theme of this conference.
Thank you so much for the very
Dr. Priya, I'll just read out the citation before you proceed, please.
Sure, sure.
This citation has been honored upon you by the Society for Indian Academy of Medical Genetics. I'll read out the citation. Dr. Priya Krishnani is Professor of Pediatrics and Chief of the Division of Medical Genetics at the Duke University Medical Center in Durham, US. She is a globally renowned expert in the treatment of rare diseases, especially Pompe's disease. Having gained considerable expertise through the design of clinical trials for enzyme replacement therapy for Pompe's, she is now a much sought after consultant for the design of clinical trials for the treatment of rare diseases. She has over 150 publications in various reputed international journals to her credit. Her research work has been aimed at bridging the gap between the bench and the clinic through its focus on translational research and therapeutic trials. Throughout her distinguished career, she has been conferred several honors and distinctions for her important contributions to academics and patient care. The Indian Academy of Medical Genetics takes pride in honoring Dr. Priya Krishnani with the Dr. Shyam S. Agarwal Oration in recognition of her valuable contributions in the field of medical genetics. Signed on behalf of the Society for Indian Academy of Medical Genetics by Dr. Shubha R. Phadke, the President, and Dr. Ashwin Dalal, the Secretary. May we have the pleasure of presenting you this citation.
Good afternoon, and thank you so much for this huge honor. For me, having trained myself in India, coming back full circle to be able to deliver a lecture at this esteemed institution and to represent the honor that has been bestowed on me, I appreciate this greatly. I hope I can do justice to this talk. And over the last day and a half, I was looking and thinking about the audience that was going to be here. And I felt that for many, the senior audience here, we've spent a large part of our career and are probably in mid-phase or later stages of our career. But if we can impact anybody, I think it is the younger people who tend to sit at the back. But I think you should all be in the front because you are at the forefront for our future. And I hope I can inspire you through this talk, how each one of you can play a role in the field of genetics or in the field of medicine. And always think big and you will have success. So this was the topic that was given to me, treatment advances in medical genetics. And I'm just going to start from the basics and then try to go into the very much newer aspects of treatment, and also how my involvement started in the field of genetics and how I felt I could make a difference. So I think in terms of therapy of genetic disorders, there's a lot that can be done at the level of prevention. So I'm not really going to go much into this because I know that you've had a number of talks on this yesterday in terms of prenatal diagnosis, pre-implantation diagnosis, and then of course preventive screening for disease onset. This particular one I want to focus on for a minute because I think there's a difference in what we are doing, whether it's predictive or whether it's pre-symptomatic. And I think for those of us in this room, we need to understand this carefully because the counseling and the implications are very, very different. So for instance, when we're doing it on an asymptomatic individual with a family history of a specific genetic disorder, we've got to determine whether or not the mutation has been inherited. So when we talk about something that's predictive, what we're really saying is that if that particular individual has that mutation, then that individual has an increased predisposition, but it's not definite that they're going to develop that disorder. For example, the breast cancer genes, right? Or the colon cancer genes. But on the other hand, when we're looking at what we say pre-symptomatic, like for instance, in Huntington's disease, or in familial adenomatous polyposis, or in myotonic dystrophy, I think our level of thinking has to be very careful because if the mutation is present, then the individual is almost certainly going to develop the disorder. So when we're doing this kind of pre-symptomatic counseling, we have to prepare the patients before that sample is drawn and to have appropriate counseling in place because we're really changing the course of their lives if they were to come back either as positive or negative. If it's negative, there's sometimes a sense of guilt. How come I didn't have it but my sibling did? So please keep this in mind as you do it. The second concept I want to talk about is metabolic manipulation. And here again, I want you to think from simple to complex. And so simple can just be as easy as dietary restriction. So someone who's got lactase deficiency, you can have lactose restriction. For someone who's got phenylketonuria, we can do restriction by restricting high phenylalanine containing foods. Or you can do a dietary supplementation. For instance, someone who has scurvy, we can provide vitamin C. If someone has been diagnosed with biotinidase deficiency, we can supply with biotin. And then there's a whole other concept of understanding a metabolic pathway and seeing where can we intervene. And I'll try and go through that as well. And then the role of chelators, enhanced excretion, as you very well know, for Wilson disease. And then metabolic inhibitors again. So think about each of these steps. We treat gout with allopurinol, but think that there's a metabolic pathway, and so you're inhibiting a pathway to help in this disorder. So if I can send you home with one take-home message, that genetics plays a role in our everyday lives, and genetics plays a role in our everyday practice of medicine. So always think pathways, always think mechanism of action, and I think you'll start identifying new treatments or challenging treatments that are placed on patients. So keep this in mind. So here is an example that when you have an underlying enzyme deficiency, it blocks the pathway. And so here is the missing enzyme. And so if you think about this intuitively, you're going to have a deficiency of the products of the missing enzyme. But on the other hand, you're going to have a buildup of the substrate, which normally would have been broken down by the enzyme. And so you have toxic products that are accumulating. And then the effects of these accumulated substrates, not only because they've accumulated, but they can have an impact on other pathways as well. So let's look at the basics of phenylalanine and tyrosine metabolism. And I promise you this would be the last of one or two of pathways, because I know it can put anyone to sleep. So here let's look at phenylalanine and how it gets converted to tyrosine, which in turn to DOPA. And see the two critical enzymes here, phenylalanine hydroxylase, tyrosine hydroxylase, but then also see that there's a role of tetrahydrobiopterin, which we see. So just looking at this pathway, we can start learning a lot. Now, if we see that there's a block here, you're going to build up phenylalanine, but you're also going to have lower levels of tyrosine, and you're also going to have lower levels of DOPA. So now when we think about PKU, it's the detection really of the elevated phenylalanine and low to normal tyrosine, which you already saw if you looked at that pathway. So when you look at a plasma amino acid profile and you start seeing some differences, go back to that pathway, and I think you'll very often get solutions right there. So the treatment, of course, there are all kinds of rules and roles, that if the phenylalanine is above a certain number, you treat. The second is that if you diagnose early, your treatment is very effective. So for instance, if you start a child at a later age, your outcome is not going to be as good as if you start treating early. So the idea of early diagnosis and the concept of newborn screening comes right into play right here. Now let's look back at this pathway, and let's look a further bit down here. And now we have this classic block here of fumarate acetoacetate hydrolase, and this is the cause of classic tyrosinemia or tyrosinemia type 1. But I want you to look at this pathway and see that here is the block, and so you're going to accumulate this substance here, and in effect, you're going to build up the precursors, which is succinyl acetone. So on a urine organic acid profile, if you see succinyl acetone, you have a clue. But more important, you can see that here is a pathway, and so if I were to block above the accumulation of succinyl acetone, I have a treatment right there. So this is the concept where NTBC or Olfidin actually came into play, where you can see now, first of all, for tyrosinemia type 1, we've already figured out that the plasma amino acids will have an elevated level of tyrosine. The second is that the urine organic acids will show you tyrosine metabolites, and you'll also see succinyl acetone, and the latter confirms the diagnosis, and many of the problems with tyrosinemia are because of the buildup of succinyl acetone. And then you can confirm the diagnosis by showing the enzyme deficiency in patient cells or by gene sequencing. But the key here is that this deficiency results in significant challenges with early liver failure and bleeding due to low coagulation factors. I'm sure many of you have managed patients with tyrosinemia, and it's a death sentence where they can develop significant liver nodules and die at a young age. And then they can also have other challenges because this enzyme is also expressed in the kidney. So once again, where is the enzyme expressed is where you're going to understand where the sequelae of that condition is going to be. So patients can have rickets with low levels of calcium due to the kidney dysfunction. And then they can have the painful crisis because of the porphyria due to this block in tyrosinemia. And then in terms of a treatment, as we talked about earlier, if you look at the pathway, this was actually a chance that occurred. They were trying to develop herbicides, and what they found out that this herbicide, NTBC or orfodin, is an inhibitor at the level above the block of succinyl acetone, and so it prevents succinyl acetone accumulation. So this today is the standard of care, but of course in addition to that you have to do restriction of protein and provide a formula that's low in phenylalanine and tyrosine, and that's the second concept. But I want to go back and show you this one particular slide, that if you block at this level, which is what we are doing, you can actually have a buildup of tyrosine if you overtreat. So once again, you have to manage the patients completely and monitor completely. So now I'm going to go to another concept of simple dietary supplementation as in biotinidase deficiency. So once again, just looking at the cycle, if you are missing this particular enzyme, you're going to need additional amounts of biotin to complete this biotin cycle. And a very, very simple treatment. You give large doses of biotin and you prevent the symptoms of biotinidase deficiency, which can range from as little as hair loss, developmental delay, to ataxia, to being in a coma, and really having significant issues. So these are the effects. If you look before biotin treatment and then after biotin treatment, you can see that not having all this loss and all this facial rash is now a much more healthy child, also who doesn't have the developmental delay. And so I want you all to take home that treatments do not have to be complex. They can be simple interventions by just understanding a pathway. And so I'll come back to one of my favorite topics, which is the glycogen storage disorders, and start from very simple to more complex. So here is the pathway, and here is where the nature of the block is for glycogen storage disease type 1. And here what you can see is glycogen gets broken down to glucose 6-phosphate and ultimately is converted into glucose. But if you have a block of this enzyme, glucose 6-phosphatase, you're going to have a challenge in making glucose, but you're also going to have a challenge from neoglucogenesis because ultimately it ends up as glucose 6-phosphate to make glucose. If I could actually make one request, please do not take any photographs because I've got patient videos here and that's against our ethics committee rules. I totally apologize for that. So what you can see here is that by looking at this block and looking at the sequelae, remember now we've got this accumulating and this is now going down other pathways. So if this goes down here, you build up pyruvate and ultimately alanine, but then you also convert from pyruvate to lactate, and then the glucose 6-phosphate goes into the pentose phosphate shunt. You get high levels of uric acid, and then the glucose 6-phosphate also gets converted via pyruvate to acetyl-CoA to make fatty acids and lipids, so cholesterol and triglycerides. So by looking at this one slide here, we've understood the metabolic sequelae of the nature of this block, which is a low glucose, which is going to be life-threatening because the child cannot make glucose either by glycogenolysis or from neoglucogenesis. The child is going to have hyperuricemia, lactic acidosis, a high level of alanine, and a hyperlipidemia. And you can guess that this child is going to start manifesting at a very young age. The moment the child stops breastfeeding or bottle feeding at regular intervals and starts to sleep through the night is when you're going to end up in trouble because the baby has no way of making glucose on its own. So once again, taking the history carefully gives you an idea of what the challenge is. And so this is where the stories begin. And this was work done by my mentor, Dr. Chen, where the description, of course, of glycogen storage disease type 1 was made earlier. So you can imagine that if you build up with glycogen and fat, and the enzyme is expressed in the liver and kidneys, they're going to have hepatomegaly and nephromegaly. And so this is an enlarged belly of this child. They have short stature. And then how do you treat these patients? You've got to prevent the hypoglycemia and correct the metabolic derangements and provide optimal nutritional support. So how can you do this? If you provided a frequent source of glucose or of energy, and this could be done either by frequent feeding or continuous glucose infusion, either through total parenteral or intragastric feeding, you can fix the problem. But do you think